Good evening. I welcome to the AIOS midterm conference at Patna. It's a very nice venue. And today we have got a session, top case in Uvea session 1. And it has got 7 cases, and all each are 4 minutes. And there is discussion, ample time of discussion is 27 minutes. So after each case there will be some discussion, okay? And welcome you all. And with this I invite Dr. Amitabh Kumar to talk on IgA nephropathy with end-stage renal disease with super added viral retinitis, a rare case report. Dr. Amitabh Kumar is from Shankar Netralaya Kolkata branch, Mukundapur, and he would be presenting this case. With me, Dr. Debashish Das from Kolkata. He is the co-convener, and co-chairperson is Dr. J.S. Valla. You will take care. You will call the names or the floor.
So, the first speaker in the session is Dr. Amitabh Kumar, and he's going to speak on IgA nephropathy with end-stage renal disease with superadded viral retinitis, a rare case report. Dr. Amitabh.
Yeah. Thank you so much. Good afternoon. I thank the scientific committee for this opportunity. I have no financial interest in my presentation. So we had a 23-year-old male from West Bengal who came to me with complaints of decreased vision in both eyes for the last 1 month. He was a known case of IgA nephropathy and end-stage renal disease on dialysis and was awaiting a transplant. He gave a history of contact with tuberculosis, his brother. His anterior segment examination, the best corrected visual acuity was 6.9 N6 in the right eye and 6.18 N10 in the left eye with a quiet anterior chamber and normal intraocular pressures. The posterior segment revealed 1+ vitreous cells with edematous and blurred disc margins, retinal hemorrhages, macular hard exudates, and exudative retinal detachment inferiorly in both the eyes, and a placoid lesion in the left eye. So this was his fundus picture where you can see the disc edema with retinal hemorrhages, macular, the hard exudates, inferior retinal detachment. And if you can see, that's the placoid lesion which we could make out in the left eye in the posterior pole. So we went ahead with an ultrasound B scan which revealed a shifting fluid in both the eyes, confirming the exudate retinal detachment. And an OCT scan at this visit revealed a CME and an NSD in the left eye. So with this clinical setting, we thought of, we had a working clinical diagnosis of malignant hypertensive retinopathy, but his blood pressure was normal. Unfortunately, we could not do an FA because of his compromised renal function. But in view of the vitritis and the placoid lesion in the left eye, we thought parallelly about an infectious etiology. So we decided to go ahead with a vitreous biopsy, and we subjected the sample to PCR for Mycobacterium tuberculosis and the viruses. And he tested positive for HSV2. So in view of the viral retinopathy, we took a consultation from the nephrologist because of his compromised renal functions. And the maximum oral dose of the oral medication which was given was a valiocyclovir 500 milligram once a day. We put him on a tapering dose of tablet prednisolone. Since he was on a suboptimal dose, we topped it up with intravitreal ganciclovir. And in a month's time, his vision improved to 6.9 N8 with regression of placoid lesion, the disappearance of retinal hemorrhages, and resolution of exudative RD. And here you can see the OCT with just some minimal subretinal fluid at the fovea. This is at 4 months where you see a flecked retina with a few hard exudates. His OCT where the subfoveal fluid resolved. This is at 6 months. His vision was 7.5 N6. He underwent a renal transplant, and he came back to me 2 years later with a best corrected visual acuity of 6.6 N6. We are keeping a close watch on him because he's still on immunosuppressive therapy. And this is his latest OCT, the right and the left eyes respectively. So to wrap up, a patient with vitritis, disc edema, macular star, flame-shade hemorrhages, and exudative retinal detachment, we thought of a malignant hypertensive retinopathy, but a vitritis and placoid lesion raised a red flag, and we went ahead with the vitreous biopsy, which tested positive for HSV2. So in these kind of clinical settings, we should have a keen eye for an infectious etiology. We should be aware of atypical presentations, A polymerase chain reaction aids in early diagnosis of a specific etiology, and an early diagnosis and appropriate treatment are keys to a favorable outcome. These are my references, and thank you for a patient hearing.
I just want to ask you that whether you ruled out syphilis in this case?
Yes, we did.
Okay. Another important thing is that did you have a CD4 count of that case?
We did. We didn't do a CD4, but we did do his ELISA.
Okay.
So he was immunocompetent.
Okay. It's a success story. And I think is that the patient responded well ultimately, and is a good thought that you suspected viral retinitis and did a vitreous biopsy. Vasculitis, when they occur in viral retinitis, retinitis is the predominant feature. Vasculitis is a secondary or added phenomena. So here in this case, retinal vasculitis was more or less more prevalent, and with the placoid lesions in the retina. Well, so this is a quite a unusual case, and anybody has described similar picture?
No, sir.
Okay. Okay. Anybody have any questions? Please.
Sir, how can you know that this is a IgA related?
No, that was the.
The biopsy or something?
No, that was a diagnosis which he already had from beforehand. He was already under the care of a nephrologist.
IgA nephropathy.
No, actually, I'm not really sure as to how we actually didn't know which way we were going, because every other sign was in favor of renal-related retinopathy, excepting that placoid lesion. I'm not sure, because his systemic condition did not change. We did not do anything to alter his systemic condition, but just with hiking up his oral steroids and putting him on the antivirals, everything resolved. So I'm not really sure what really worked.
Sir, it was a bilateral axillary RD.
Yes.
So, and the patient was hypertensive or not hypertensive?
No, he had a secondary.
That bilateral axillary RD is because of hypertension.
Yeah, I know. So he had a CKD. He had a chronic kidney disease. So all the other signs were in favor of a CKD. So the only thing which made us think about an infectious etiology was the vitritis and that placoid lesion. Yes. So that's the only thing which pointed towards an infectious etiology, and especially because he was on dialysis. So we thought that we did do his immune status, and he was immunocompetent.
In chronic renal failures, we do get macular edemas, and this case is a renal failure case. So might be as an exaggerated form of a macular edema, causing neurosensory detachment as well as retinal edema. That might explain the amount of edema it was having.
Okay. Due to the constraint of time, I think this is 4:08. We will go to that next paper. Next paper will be called by Devashish.
So may we invite Dr. Shivangi Kapoor. Her topic of discussion is the headlights in the fog. Is it toxoplasma or something else? An unusual case of pediatric panuveitis. Yes, Dr. Kapoor.
Yes.
Next we will call.
Good afternoon, everyone. Today I am presenting a case of a 14-year-old girl resident of Lakhimpur presented in our OPD with blurring of vision in both eyes since 2 weeks. Blurring of vision in left eye followed by right eye that was sudden in onset, painless, progressive in nature. There was no history of cough, headache, trauma, joint pain, backache, oral or genital ulcers. There was a past history of typhoid fever 1 month back. There was a contact history with dog and cattle. Patient was treated elsewhere with tablet cotrimoxazole, BID, tablet azithromycin. As the patient was not improving, patient was shifted on acyclovir 800 mg 5 times a day and oral steroid was started from last 1 week. Ocular examination was done. Position of head, eyelids and lacrimal apparatus were within normal limit. Right eye uncorrected visual acuity was 1/60. Left eye it was 3/60. Near vision was less than N36 in both the eyes. Anterior segment examination was within normal limit except anterior chamber. Cells +1 and flare +1 was present in both the eyes. Fundus examination was done with indirect ophthalmoscopy. Right eye media was hazy due to dense vitritis and multiple whitish, creamish whitish lesions were seen in the posterior pole that was 1 to 2 disc diameter in size. In left eye, media was comparatively better from the right eye and similar lesions were seen in the posterior pole and we can see the disc was also hyperemic. In the left eye and the in the periphery, we can see a large subretinal lesion, 2 to 3 disc diameter in size with speck of heme was present. These were the investigation done elsewhere. Polymorph or reduced Montoux was negative, ELISA for torch, IgG, HSV1 and 2 and toxoplasma came out positive. USG B scan of the right eye was done, vitreous echoes with increased retinochoroidal thickness was seen. AC tab was done, PCR was negative for eubacterium and pan-fungal genome. As media was relatively better in the left eye, fundus fluorescent angiography was done. In the late phases of the angiography, we could see an incomplete ring of fire appearance. So the history was revisited and the patient was re-evaluated and it came that patient had a history of consumption of raw milk since last 2 months. So USG abdomen was done. There was an increased thickness of ileocecal wall and enlargement of lymph nodes was seen. So patient was suspected of having intestinal cox and patient was referred to the pediatrician for starting appropriate ATT regime. After 2 days of starting ATT regime, we started oral steroid and this was the result. After 4 weeks of ATT, right eye vision was 612 and N8 and best corrected visual acuity of left eye was 69 N8. So this was a case of pan-uveitis, pediatric pan-uveitis secondary to tuberculosis. Thank you.
What are the points in favor of tuberculosis? It looks more like a toxo to me.
So initially we thought initial differentials were like endogenous and off because patient was having a history of typhoid fever and then we were suspecting viral retinitis also. So toxo, it was because multiple lesions were there and the patient was also immunocompetent. Patient was not immunocompromised and in multiple posterior pole lesions, it is a atypical presentation for toxo.
Can it be TB toxo together?
So it can be. So and we in the left eye we could see in the periphery there was a large granuloma type of lesion, 2 to 3 disc diameter, and a speck of heme was also present. It was going in favor of tuberculosis.
OCT would have been a very good thing to find out where is the site of lesion, retina or
Correct.
retina or retinochoroid or only choroid.
So, but the media was very hazy. In the right eye, we did B scan because it was hardly visible, and in the left eye, FFA was done, but OCT it was not visible.
Toxo produces vitreous haze, but vitreous haze is toxo is often localized.
Yes, sir.
So it's a little unusual to. TB also doesn't produce that much of vitritis.
What are the positive findings specifically in favor of tuberculosis? Only the ultrasound have come?
Yes, sir. Consumption of raw milk was there, but it was non-specific because other than that there was no such history of tuberculosis or contact history was present. And in USG B scan there was a suspect because there was increased thickness and enlargement of lymph nodes were there.
Fluorescent angiography ring of fire appearance is a sign of choroiditis, but it's not really the pathognomic of
Yes, sir.
tuberculosis.
Test might be started in benefit of doubt, ATT on benefit of doubt with the node in the abdomen and like this. So for that reason you have started.
Sir, we were suspecting extrapulmonary tuberculosis and because the lesions, we were suspecting tuberculosis, and there was intestinal cox also we were suspecting, so we started ATT. After that we started steroid.
Because you have started earlier, prednisolone with
Someone else started, sir.
trimethoprim and also azithromycin you have started earlier.
Azithromycin, cotrimoxazole and acyclovir and steroid were started before the patient presented to us. And still the patient was not responding to that treatment.
So ultimately, what do you think the patient responded to? Was it the steroids or?
A combination of both ATT, and after that we started steroid.
And you had the picture after the patient?
Yes, yes, sir. Yes, ma'am. We have. This is the picture. After 4 weeks of starting ATT, and then after starting ATT, after 2 days we started oral steroids.
The lesion in the left eye looks like there's a old deep scar and then there's another lesion next to it.
So this is after 4 weeks. Before 4 weeks, this was a large granuloma type of lesion. This one was coming like ring of fire appearance. This lesion. This lesion has reduced after 4 weeks. There was improving, the vitritis has improved and the lesions are resolving.
Joby sir.
So, so although it responded to the treatment, my way of, my sixth sense is telling me that it's a toxo only. So I don't know how to defend myself.
I
But
think
is,
it responded to steroid, not to ATT.
yeah.
Sir, the patient, I think, that was started on typical antitoxin, azithromycin and bactrim.
That is an antitoxin only initially.
After 3 days, they have started that oral steroids, and the patient deteriorated actually.
Vision deteriorated.
And still the situation was same. So then we decided that there is something missing. Then we planned, we revisited the history, and the patient simply said that the patient was having that raw milk from last 2 months. Then we suspected that something is wrong and that mild abdominal ache was there. So we asked to go for ultrasound abdomen, and ultrasound abdomen was diagnostic of that intestinal cox.
See, the raw milk is a long time was thought to be earlier. Wood's time, Alan C. Wood's time, they used to think that the brucellosis is one of the cause of the uveitis. But brucellosis later on has not been found to be an important cause of uveitis or choroiditis. I just reviewed an article on brucellosis. This is going to get published soon. And they said that various manifestations, even choroiditis, can be due to brucellosis.
Sir, one question. Whether in immunocompetent patient, can toxoplasma present with so many
Multiple lesions.
Yeah. Bilateral it can be. Even immunocompetent can have bilateral. I have a case of peripheral toxoplasma. I was thinking of toxocara only, and later on when the patient pops out with a posterior pole lesion, I thought that my diagnosis of toxoplasma was correct, and it turned out to be toxoplasma positive. Initially it was a negative for ELISA for toxoplasma. So we'll go to the next case.
Thank you, sir. Thank you, ma'am. Thank you, ma'am.
Next presenter is Dr. Rani Bhattacharya. She will be presenting a rare case of ocular tuberculosis with underlying tubercular meningitis.
A very warm good evening to one and all present here. I, Dr. Lani Bhattacharya, welcome you all to my case presentation on a rare case of ocular tuberculosis with underlying tubercular meningitis. Tuberculosis is one of the leading causes of morbidity and mortality worldwide. Ocular TB refers to extrapulmonary TB involving active infection of the ocular tissue by Mycobacterium tuberculosis or secondary immunological response to the organism elsewhere in the body. So a 22-year-old girl presented to us with chronic headache, diminution of vision both eyes since the last 2 months. It was associated with low-grade fever, night chills, nausea, and neck rigidity. There is no history of restricted ocular movement, diplopia, drooping of eyelids, cough, or altered sensorium. She doesn't have any known systemic illness. General and systemic examination revealed neck rigidity, that is, Brzezinski sign was positive. On ocular examination, best corrected visual acuity of the right eye was 3/60 and 1/60 on the left eye. Cornea, fine and medium-sized keratic precipitates were found on both the eyes. Anterior chamber revealed cells and flare of grade 2. Pupil was round, regular, reacting to light on the right side, and REPT was found on the left side. In the lens, iris pigments were seen over the anterior capsule, indicative of previous synechia. Extraocular movements and IOP were within normal limits. We can see in the image medium-sized keratic precipitates over the cornea. This is the fundus examination. We can find vitreous haze of grade 1 and mild blurring of disc margin was seen. OCT was done, which was within normal limit of the optic nerve head as well as macular thickness. Fundus fluorescent angiography was done, which revealed late disc leakage, which can be seen in the last image. So we suspected this to be a case of pan-uveitis, and the entire uveitic profile was done, including complete hemogram, sugar levels, RA factor, CRP, etc. So the patient was found to be quantiferum TB gold positive, HIV was negative, ESR was 60 millimeter per hour. However, chest X-ray was found to be normal. So since the patient presented to us with neck rigidity, we went on with a CECT brain and found that enhancing exudates in the basal and suprasellar cistern extending along the adjacent leptomeninges, suggestive of meningitis. CSF analysis was done, lymphocytosis was found with high protein and low glucose content, Zn stain was positive, suggestive of acid-fast bacilli. So the patient was then admitted under neurology and started on antitubercular therapy, and adjuvant IV corticosteroids was started, which was tapered gradually for 1 month, followed by oral dexamethasone, which was tapered weekly for 1 month. From ophthalmic side, we started prednisolone too early initially and tapered weekly for 2 months, and eye drop atropine was given thrice daily, which is still continued. So after the intensive phase of ATT, the visual acuity in the right eye was 6/60 and in the left eye it was 3/60. KP was still present in the cornea, and anterior chamber was deep and quiet, that is, cells and flare had reduced. Pupil was reacting in the right eye, and RAPD was present in the left eye. This is the fundus imaging in the right eye. Peripheral vascular sheathing was present, and macular star formation happened. In the left eye, pale disc was seen, and macular star formation was seen. So coming to discussion, a clinical diagnosis of ocular TB is difficult due to its varied presentation and often indistinguishable from other causes of uveitis. Most common presentation of intraocular TB is posterior uveitis. Pan-uveitis is relatively uncommon. The gold standard is positive culture from ocular tissue. According to Gupta et al., antitubercular and adjuvant corticosteroid is the mainstay for both ocular TB and TB meningitis. However, high CSF protein content and ethambutol intake are precipitating factors. So coming to conclusion, extrapulmonary tuberculosis like tubercular meningitis may rarely present first to an ophthalmologist. High index of suspicion in tuberculosis endemic areas is a must for prompt diagnosis, and standardization of treatment along with extrapulmonary involvement should be done. These are my references. Thank you.
We do see a lot of extrapulmonary tuberculosis, but CNS tuberculosis and ocular tuberculosis is not that very common, as we see in the CNS encephalitis and viral encephalitis and viral retinitis. That way we don't see that frequently. What made you suspect that this is a tubercular uveitis?
So firstly, she presented to us with a chronic headache, and she had neck rigidity. So we, indirectly, somehow during the examination time only, we found that she was presenting with neck rigidity. So we were lucky in that case that we saw neck rigidity at that point.
No, sir's question was different. How do you suspect ocular tuberculosis in a case presenting with TB meningitis? So that was the question.
I guess in TB meningitis, every patient is referred to an ophthalmologist for evaluation.
That's what sir said. They are not very much clinically correlated as in cases of the viral etiology cases. We do not get so frequent number of cases with ocular tuberculosis associated with tubercular meningitis. So what made you suspect that? Got his question.
So in our case, the patient first, we thought it to be a uveitis case, which ultimately went. I'm not
If I
getting your
understand
question, sir.
correctly, the answer would be that because the patient had neck rigidity,
Yeah,
because you
which is why we
diligently
went.
examined, so you got the
We
neuro
went on to do
consultation.
meningitis. Actually, we suspected meningitis. We did not suspect
Right.
TB as such,
Basically, you
but because
suspected the same etiology working for both the patterns.
yeah,
So
Correct.
once it was detected
we
by
did the
the
entire profile for uveitis when the patient presented with matlab quantiferon TB was positive. Then like because meningitis, uveitis, and then quantiferon TB was positive, so finally TB meningitis and ocular TB.
But don't depend on quantiferon TB gold test alone,
Yes.
because clinically it should be consistent with tubercular uveitis. I know that patient ultimately showed good improvement.
The question I had was the neurological opinion consistent with tubercular meningitis?
Yes, ma'am. Like the
the
contrast
radiological
enhanced
diagnosis-
radiological, yes, ma'am. And CSF analysis also, ma'am, showed.
Papilledema is there. Papillitis is there. That is the reason why this patient is with you.
Sorry, sir.
Because patient is having reduced vision.
Yes, sir.
And your ophthalmoscopic finding is like this. For
This.
that reason, you have examined and find out this Buddhist sign or the.
No, sir. No, sir. This is the follow-up. This is after patient was treated. Like this is after 2 months.
Okay.
Initially, the presentation was this.
Okay.
And because the patient had Brzezinski's sign,
Sir was asking.
Oh.
no.
So why you have? So sir
But,
was asking about this.
but good for the patient that you made a diagnosis.
Yes, so we were lucky in that case, and patient was also lucky, sir.
I have only one objection with your presentation.
Yes,
You wished
ma'am.
us a very warm evening.
Oh, yes, ma'am. Yeah, yeah. Sir, I guess, I guess the patient, like, it was a case of pan-uveitis. Like, gradually we found anterior uveitis first, then intermediate uveitis was present.
It is because of resolution of fluids and giving rise to exudates. And
Initially, this was not the
this
case. Yes, sir.
If you see a neuroretinitis, suspect Bartonella first.
Okay. Yes, sir.
what about the vision?
Vision has improved because I think, from my point of view, I think vision has relatively improved because of.
It is because of
Yes, sir. Which is one of my point in discussion that high protein content and ethambutol intake are kind of promote towards optic atrophy. So, yes, sir. Ye-
Sure.
Yes, sir. Yes, sir.
Yeah.
Because OCT of your, just show the OCT picture initially, there is hardly any
That is,
edema.
yes, sir. It's normal.
OCT is
Yes, sir.
absolutely normal. It's 2
Sir-
months after starting treatment that you are having macular edema.
Sir, I have a question. Can it be because of papillitis, like because the patient presented with RAPD in the left eye? Or
That
I
could
don't
be.
know.
Okay.
Okay.
No, but it's good for the patient. You made a diagnosis. And
The question I had for the initial presentation is that the visual acuities are very poor for the density of vitritis because you could get clear fundus images, you could get OCT. You said there's some vitritis. So why is the visual acuity so
Ma'am,
poor?
there was anterior uveitis as well as, I think because of the KP as well, and in the left eye because,
If you can get such a clear view, the visual acuity shouldn't be 3/60 and 1/60.
okay.
OCT comes out good. OCT picture is good.
But Ritchie's haze is grade 1, sir.
Hmm.
So maybe there's some optic neuropathy component as well.
Yeah.
And I completely agree that so if maybe you don't, this was not the peak of the disease. So this disease in evolution. And so the intermittent visits are missing, or we don't have that. And 2 months later, what you have is much more affectation of the tissue than you have right now. And you don't have an OCT, the 2-month OCT, so
No,
we don't know
ma'am.
whether that's
Yes, ma'am.
edema or it's scarring.
We'll move to the next case.
Thank you. Thank you, ma'am. Thank you so much.
Devashish.
With this, thank you, Dr. Lani. With this, we call Dr. Ujjwala Pandey for her presentation, a case of ocular tuberculosis. Dr. Pandey, please.
And I am going to present that.
Good evening, everyone. I would like to present my case on ocular tuberculosis. I have no financial interest and no conflicts of interest. So India is the highest TB burden country, and tuberculosis affects every fourth person on the planet and is the leading cause of death from a single agent worldwide. The term ocular tuberculosis describes an infection by the Mycobacterium tuberculosis species that can affect any part of the eye, intraocular, superficial, or surrounding the eye, with or without systemic involvement. So there is presumptive ocular TB, possible ocular TB, and clinically diagnosed ocular TB. So clinically diagnosed ocular TB is one in which there are clinical signs suggestive of ocular tuberculosis, along with... I present you a case of a 65-year-old male who presented with a history of blurring of vision in the right eye with floaters since 3 months and on and off redness since 2 months. Patient denied any history of weight loss and fever. On ocular examination, there was irregular pupil with broad-based synecdoche at 2 o'clock, 3 o'clock, and 7 o'clock. The best corrected visual acuity was 6/36 in the right eye with normal intraocular pressure. On examination, the left eye appeared to be normal. So this was the fundus photo of the right eye showing hazy media with perivasculitis type of features in the superior quadrant. The left eye appeared to be within normal limits. This is the OCT of the right eye. The media was very hazy, but we did see that the retina was thickened with the average thickness of 327.7 microns. This is the OCT angiography of the right eye, where we can see mildly distorted foveal vascular zone along with a mild venous dilatation present superiorly. Left eye OCT angiography appeared to be within normal limits. So HRCT thorax of the patient was advised, which showed patchy areas of consolidation in bilateral lung fields. Along with that, the patient also had Montague's test positive with 30 mm induration. The ZN staining was 2+, and the quantiferon TB gold test was positive. Investigations including complete hemogram, ESR, RA factor, HLA typing, and ACE were also performed. With assistance from the Department of Pulmonary Medicine, we started the patient on isoniazid, rifampicin, pyrazinamide, and ethambutol for 2 months, followed by isoniazid and rifampicin for the next 7 months. So patient was also started on tablet prednisolone 60 milligram, which was tapered gradually, and patient was started on eye drop prednisolone, initially 2 hourly, which was gradually tapered, along with eye drop atropine sulfate 1% TDS. So this was the OCT picture, 2 months. Where we can see that it appears to be somewhat normal, but though still the retinal thickness was 302.4. Along with that, we can see that the haze has suppressed, but there are still features of perivasculitis present. The BCVA of the patient on that visit was 6.9. So ocular tuberculosis, the patient is still on follow-up. The patient, ocular tuberculosis represents a major diagnostic and therapeutic challenge due to its heterogeneous clinical manifestations, mixed ocular tissue involvement, lack of diagnostic criteria, and gold standard tests. Collaborative ocular tuberculosis study 1 has shown posterior uveitis to be the most common phenotype in tuberculous uveitis. Gupta et al. Reported broad-based posterior synecdoche to be the most frequent finding in tuberculous anterior uveitis. According to the COTSCON, in active retinal vasculitis, any immunological positivity along with radiological support or immunological evidence involving both PPD and IGRA positivity without radiological findings supports the initiation of ATT irrespective of the endemicity. These guidelines indicate that active ocular disease with evidence of TB infection deserves treatment and will potentially impact the public health measures in the management of extrapulmonary tuberculosis. So, conclusion, ocular tuberculosis can range from diagnostic dilemma to treatment incompliance. Because of the lack of diagnostic criteria, it is often difficult to initiate ATT. Ophthalmologists should be very careful to diagnose the disease and its treatment response. The recognition of clinical signs of ocular tuberculosis is crucial as it can provide a clinical pathway towards tailored investigation and decision making for initiating anti-tuberculosis therapy. These are my references. Thank you.
Ocular tuberculosis has got protein manifestation.
Yes, sir.
But there are a lot of lights has been thrown up in the recent 10 years, last 10 years, including Professor Ahmad Gupta's description of the diagnostic criteria of ocular tuberculosis or tubercular uveitis in particular, has said that broad-based pustular synechiae, multifocal serpiginoid, choroiditis, tuberculum of the choroid, and I also feel that even subretinal abscess is a often diagnostic of tubercular etiology and should be supported by supported by the investigations for tuberculosis. So this is not really is a that much of challenge. I feel.
Yes.
This your case. Retinal vasculitis with broad-based posterior synechiae has been well described recent years from India.
Can we go for the next?
You consider doing any further investigations?
Any further investigations?
Or like invasive investigations?
No, sir. We didn't give any other investigations. We did not advise for any other investigations. We did think of FFA, but then by the advice of our professors, we went on with OCT angiography.
Anybody has got questions? So this is a very common phenomena. Is a eye-specific tuberculosis is a now well-recognized entity. So way back in 1995, I went to a TB center and seen 1,005 patients of pulmonary tuberculosis and did not find much of the TB cases. Only 14 cases were found, 1.39% positivity. So it doesn't go hand in hand like pulmonary tuberculosis or systemic tuberculosis and ocular tuberculosis. Ocular tuberculosis is definitely a separate entity which is limited to the eye only, and it has got a very good diagnostic science which has been amply provided by Professor Ahmad Gupta and some of us.
Thank you, sir.
In the interest of time, we'll go on to the next presenter. The next case is by Dr. Ghazal Patnaik. So Dr. Patnaik is presenting UV diffusion syndrome due to WNT10 mutation. While she's setting up a laptop, Rashmika, that is very difficult, especially if you're not working in an institute or in a multi-specialty hospital. So the only way out is to have a dialogue with the physician who will treat the patient. So and to go and talk to them and keep on sending them such cases and gradually, or maybe literature. So you have to find a colleague who is willing to listen to you. Yes, exactly. Yeah, that's good.
They also don't feel safe themselves when they ATT because they say the lung is clear.
Right.
Where is the TB?
Because the medical legal liability becomes an issue if there's any side effect of the medication that happens systemically. So
For the ethambutol.
Ghazal is ready. You can start.
A very good evening, everyone, respected panel. I shall be presenting a challenging case of exudative retinal detachment. It has challenges revolving around all the aspects of diagnosis, investigation and management. So it's a case of a 32-year-old male came to us with diminution of vision in the left eye since 2 weeks. He had simultaneous onset of headache and tinnitus. The best corrected visual acuity was 20/20 in the right eye, 20/80 in the left eye. Intraocular pressure and the slit lamp biomicroscopy was within normal limits in both the eyes. Fundus examination revealed 360 degrees choroidal detachment as can be evident in the B scan, and there was presence of retinal detachment inferiorly in the left eye. Fundus fluorescein angiography and indocyanine grain angiography showed presence of inflammation in both the eyes with blocked fluorescence due to retinal detachment in the left eye. The OCT showed presence of subretinal fluid with hyperreflective foci and a bumpy lumpy RPE, retinal pigment epithelium, in the left eye. At this point, patient received a diagnosis of Vogt-Koyanagi-Harada syndrome and received pulse intravenous methylprednisolone followed by tapering doses of systemic corticosteroids and systemic azathioprine. 1 month later, although the patient was relieved symptomatically, headache and tinnitus subsided, the best corrected visual acuity was maintained at 20/80, and we saw a leopard spot retinopathy in the left eye with persistence of retinal detachment and thickened choroid, although the choroidal detachment has resolved. At this point, fundus fluorescein angiography and ICG, although showed resolution of the inflammation, there was persistence of retinal detachment and an increase in the leopard spot in the left eye. The OCT also showed resolution of subretinal fluid. However, the hyperreflective foci and the bumpiness of the RP persisted. So at this point, the diagnosis was revisited and PET CT scan and MRI brain and orbit was ordered to rule out a presence of any lymphoma or systemic malignancy. There was absence of both this. At this point, another imaging was reverted back, which showed presence of uveal effusion, and the patient was diagnosed to have uveal effusion syndrome type 3 as the axial length was 20.97. Patient received posterior subtenon, all the immunosuppressive agent systemically was taken off, and 3 months later the best corrected visual acuity improved to 20/30, but there was persistence of retinal detachment inferiorly in the left eye. The challenge does not end here. Systemically, we had challenges. The patient at the baseline was looking like this, and in a subsequent visit, we noticed a sparseness of the hair and an absence of dentition. That were 7 permanent tints were present in that patient. Similar systemic features was noted in his mother, and so a genetic counseling was done which revealed WNT10A gene abnormality. So what was known before that? This uveal effusion syndrome is a very rare cause of exudative RD. Imaging comes handy. Systemic immunosuppression are not much effective. Familiar cases, only one has reported from India, and type 3 is very rare. WNT is a new one. So all these etiologies are not idiopathic. This could be a new one, new window towards a new pathology underlying this rare entity, and it has been implied in ectodermal dysplasia, and they are involved in tight junctions formation. So our hypothesis is that it might affect the interphotoreceptor matrix through its expression in the intercellular adhesion molecules and vascular endothelial growth factors. So it's an entity of diagnostic challenge. Careful evaluation is noted, and we report the first case of uveal effusion syndrome with WNT. Thank you.
What are the other manifestations of the WNT10A gene?
So, systemically, it has issues with the ectodermal dysplasias like hair, skin, and dentitions. From ocular side, it has been noted in keratoconus and in retinal diseases like FEVR, familiar exudative vitreoretinopathy, and age-related macular degeneration. But it has never been reported in uveitic condition.
Very rare case, yes.
Does the life expectancy remain the same? Normal.
Sir, yes, sir. Life is not affected because it affects only the ectodermal lineage, does not affect any other lineage. Yes, sir. No, sir. Like WNT in ocular condition, very rarely associated with all these corneal conditions where it affects the stromal transportation. In retinal condition, again, where it affects the interphotoreceptor adhesions. So, cataract, it has not been yet associated.
Thank you, Ghazal.
Thank you.
We'll move on to the next presenter, Dr. Santosh Mahapatra. He's talking about bilateral panuveitis with orogenital ulcers. Again, that's routine old disseminated tuberculosis versus syphilis or Behçet's. That's a differential diagnosis for his case. He has 4 minutes, and after that will be the last case, I think. There any more, apart from Dr. Aritra, any more presenters? Okay, this is the second last for this session.
So good afternoon, one and all. A lot of discussion have already been made regarding ocular tuberculosis. But this case, I think we are not sure. This patient is a 52-year-old male who presented to us with a gradual painless diminution of vision in both the eyes for 2 months with a visual acuity of counting finger 2 meter and 3 meter in right and left eye respectively. IOP was normal. Anterior segment showed early cataract but moderate cells and flare. And fundus examination revealed grade 2 vitreous haze with multifocal choroidal patch, edematous hyperthermic optic disc, but no vascular seeding, but on indentation, snowball exudates were appreciable. The systemic examination showed there was no fever, there was moderate weight loss, no lymphadenopathy, and there was no contact history, and the patient didn't agree for the pathology test. There are both mouth ulcers as well as genital ulcers. So, provisional diagnosis of a case of sudden acute infectious panuveitis with retinitis or retinochoroiditis and orogenital ulcers in a patient with hypertension and other comorbidities kept in mind, and other blood tests were done. So, to me, I think we 3 possible diagnoses came to my mind, like tertiary syphilis, Behçet's, or ocular disseminated tuberculosis, because of these blood findings with mild lymphocytosis. ESR was 45 millimeter, VDRL was positive. Mantoux showed a strong reaction of 15 millimeter. So, with after 4 days, when you again took picture, the choroiditis patches are more prominent. Vitreous was started little bit clearing, so we could take good picture. OCT was normal, and posterior pole appear normal. The angiogram showed disc hyperfluorescence and peripheral patches of choroiditis.
TPHA has been done?
Yes, sir. I am coming to that. I'll discuss one entity individually. TPHA was negative. I'll come to that.
Oh, okay.
So, with disc hyperfluorescence and early hypo and late hyperfluorescence of the choroiditis patches. So, as Dr. Viswas was asking, we did TPHA, which was negative, which ruled out syphilis. Behçet's, it was difficult to rule out because the patient denied for pathology and genetic subtyping was not done. So, the third entity which were in our mind was tuberculosis, and it was supported by a strong Mantoux as well as high ESR. But we lost the patient to follow up, but we have ordered for ATT and oral steroid. As to support our diagnosis, we searched the literature, and it was found that a good number of cases had oral and genital tuberculosis to present as a relatively rare manifestation of tuberculosis. So, the take-home message is common diseases can have uncommon or overlapping presentations, and one should look for it to cleanse them early for better possible outcome. Thank you.
I like to think common thing first, and 2 plus 2 I want to make it 4, and I would consider that Behçet's disease would be the first possibility in this case. The Behçet's disease patients, nothing prevents them for getting a Mantoux positivity, because tuberculosis is a predominant systemic disease, systemic infection in our country. to have oral as well as the genital ulcer due to TB and also having an retinitis lesion is due to TB, to my mind is quite unlikely. And you don't need an HLA-B typing. And actually I talked with Dr. Tutkun, who is an authority on Behçet's disease. They stopped doing that HLA typing for Behçet's disease now. They say that it's so non-specific.
So I agree with you, sir, because the patient did not turn off. I have ordered for the pathology, and first time he did not agree. We could have done it next time when he comes. So might be.
In fact, I did a paper with sir only. So in Indian subcontinent, the Behçet's presentations are not always the scheduled, the four categories it has, and rather it has a milder variations presenting with one or two symptoms, signs, one or two signs. It does have.
Incomplete Behçet's.
Incomplete Behçet's.
You need to have oral aphthous ulcer to call it Behçet's uveitis. That's a must, IBD classification. Is it Behçet's? I'll put money on that.
Full amount.
No, I just do. I'm not saying that I'm all the time correct, but I'll put my money on Behçet's. We'll move to the next case.
Yeah.
There's
Thank you.
25
Thank you,
minutes.
sir.
Next case.
Good evening, everyone. My name is Dr. Aritra Khatak. Good evening, everybody. My name is Dr. Aritra Khatak from Sri Sangadeva Netralaya. I'm PGT. I'll be presenting a case on focal retinal pigment epithelial defect in a case of metachondromatosis. We presented with an 11-year-old female with a history of trauma in the right eye 1 month ago that led to vitreous hemorrhage and was diagnosed elsewhere. She presented to us in the outpatient department with a diminution of vision and resolved vitreous hemorrhage. On examination, the vision in right eye was found to be 6/24, which was improving to 6/18 from 18 via pinhole. We did not find any relative afferent pupillary defect, and the anterior chamber was quiet in this patient. Fundus examination, we found a retinal pigment epithelial atrophy in the right eye. On systemic evaluation, we found multiple enchondromas was found in the hand, and genu valgum of the leg was very prominent. The CT scan of the whole body showed multiple eccentric bony projections directed from parent cortex and internal trabeculae, continuous with the lesions suggestive of osteochondromas in the patient. The MRI brain was within normal limits, but segmental CT scan images showed osteochondromas in the iliac crest and the tubular bones. Metachondromatosis is a skeletal disorder affecting the growth of bones, leading to multiple enchondromas and osteochondromas. It is an autosomal dominant condition, and the condition affects the tubular bones, the vertebrae, the small and flat bones. Ocular association as retinal pigment defect is rare. The systemic examination revealed multiple osteomas in the body. There was no gastrointestinal problem, but the CT scan of the whole body revealed multiple exostosis and was diagnosed as metachondromatosis. The patient was subsequently consulted with an orthopedic surgeon. The strong differential diagnosis would be multiple osteochondromas, but other signs and symptoms of syndromic complex was absent in the patient. Biopsy was not done in a patient. The whole CT scan was helpful to pick up the lesions, and in the family history, she was the only one to be involved. No parental consanguinity was noted, and the patient was referred to the orthopedic surgeon, and she is currently attending school with average performance. Thank you. My references. Thank you.
Heard or seen a case of like this?
Yes, ma'am, sir.
I have not seen or heard of a case like this.
Yes.
So it's a very rare case indeed.
Yes, sir. She presented with an RP defect in the right eye with multiple exostosis of the body.
Thank you. Good case.
Thank you, sir. Thank you, sir.
So, Shomshila, you will close the session?
Sure, sir. So I think that we had really challenging cases in this session. really tough cases. Of course, 4 out of 5 were tubercular, I think, or 4 out of 6. And the other 2 also we had, so tubercular again wins the game today, and we lose the
See,
game today.
you are sitting in the heart of India.
And all of them really taught us a lot about how we should have a thorough clinical examination, like the sign of nuchal rigidity really opened up the case in terms of tubercular meningitis. So, and your cases with the aphthous ulcers, most likely to be Behçet's. So Dr.
Very
JB
nice
is
cases.
putting 1 lakh on it. So
More than that.
more than, and he's probably right. So yeah, so thank you everyone, and thanks for all the chairs and co-chairs.
We finished in time.
And nobody needs to get up because the next session is also uveitis.
You get a 5 minutes, 5 tea break now. It's 4:54. How much is it?
Okay, so 5 minutes. If you say,
5
bring
minutes.
your tea. 5 minutes to go. Get your tea and bring it here.
Is it the same panel?
It's not the same panel. Almost, it is you, and it's the same panel, more or less.
End
Yeah,
the session.
only some of us get off the stage.
You have ended the session.
Yeah, you're there. Yeah, and
Yeah.
JB is there, and Devesh is there. Yes, of course.
Sure.